Okay, welcome back to part 4. So in this part, we're going to go through the perfusion maps and understand how they're created and what each map looks at. It's important to know that as radiographers, we don't need to know this as in depth as I'm going to go through today, but I find it's handy to know how things are calculated and why they're done to understand the maps better. Okay, so just quickly, our learning objectives for this lesson are define and understand key terms to ensure a solid foundation in the language and concepts used in CT brain perfusion studies. Distinguish between the core of the brain injury and the penumbra, and understanding the physiological and clinical significance of each area in the stroke. And gain skills in interpreting the main maps generated from CT perfusion. So these are the cerebral blood volume, CBF, cerebral blood volume, CBV, mean transit time, MTT. So this objective will focus on how these maps are used to identify areas of core and penumbra. Okay, so what are we looking for when we scan a brain perfusion? So the cerebral metabolic needs are highly dependent on continuous blood supply. So with blood flow interruption, brain function is impaired within seconds and irreversible damage can occur within minutes. So when we talk about the term perfusion, so we're talking about the process that involves the delivery of oxygen and nutrients to our brain tissue while simultaneously removing carbon dioxide and waste through the network of vasculature within our brain. So in the context of perfusion imaging, we're essentially using our contrast bolus and how this flows through the brain and mapping that to the physiological process of that blood transfer to try and give us an idea of how that blood is moving through our brain and if there are any deficits. So this is scanned over time. So like I mentioned in a previous video, it's more like a movie than it is a photo. So we're capturing that contrast flow as the patient goes back and forward through the scanner to get a good idea of how that blood is moving around the overall brain tissue over a length of the 45 seconds to a minute that we scan our brain for in our perfusion studies. So how does it do this? So we've got to essentially compare apples to apples. So as I mentioned in a previous video, once again, it doesn't look at a baseline set of data that we say this is what the brain should be doing and this is how that contrast should be flowing through the brain. It looks at one side of the brain to the other side. So we're comparing the damaged brain tissue to the healthy brain tissue of that patient, not of an ideal value. Okay, so now let's take a look at what our perfusion software is actually doing. So we know that it's looking at the contrast flow through our brain, and it's correlating this to what the blood is doing through our brain tissue to try and give us maps so that we can work out what's our core, so essentially our already dead tissue, and what's our penumbra. So our penumbra is what we're looking for, so it's our salvageable or at-risk tissue. So rather than think of our brain as brain tissue for the time being, let's just think of it as two tanks or silos. So we're going to look at our flow into our tanks. So that's our arterial input, so our blood flowing into our tissue. And then we're going to look at how that drains out, or our venous return. So this is called our CBF, or our cerebral blood flow. And essentially what this is the amount of blood flowing through a given volume of brain in a specific amount of time. So this is measured in milliliters per 100 mils per minute. And what we're looking for when looking at our CBF maps is identifying areas of hypoperfusion, so reduced flow. So the areas that will have our reduced flow will be our infarcted core and also our penumbra. So all of the tissue that suffered the stroke event will have a reduced flow. So the infarcted core though should have a markedly decreased CBF. So then we look at the volume of blood flowing through a given volume of brain, or our CBV. So this is essentially how much blood is within those tanks. So the ischemic penumbra should have a normal CBV, whereas our core will have a reduced CBV. So there's no longer that blood volume in our core, and that's why it's already dead or ischemic, whereas a penumbra still has a high or normal CBV. So if we restore that flow, that tissue should still be salvageable. So sometimes our penumbra can actually have a slightly increased CBV. So this is due to what's called autoregulation. And so that's the ability of the brain's vasculature to actually try and maintain stable blood flow to the brain. So this will normally try and adjust the blood flow due to things like increases in blood pressure. But so when you're having a stroke, the brain might actually reduce the venous output to try and keep that blood volume in the tissue, and therefore actually help in the ability that if you can restore that flow, that blood is still in that tissue and it's still viable, salvageable tissue. So that's our CBV, our cerebral blood volume. So our blood flow is our input and output, and our blood volume is how much blood is within that tissue, or in this case, how full our tanks are. Okay, so let's start by taking a look at our two empty tanks. So, for this sake, our left side is going to be our healthy tissue, and our right side is going to be our core tissue. So let's start by looking at the blood flow of our normal tank. So notice on the other side that our tank is filling at a much slower rate. So this would be classified as decreased blood flow. So then, on our normal tank, we notice the tanks fill up almost to the top of the tank, whereas on our stroke side, we know it is only filling up to about a third of the way. So this means we have a reduced cerebral blood volume on the right-hand side. So, if our flow is reduced, we know we have ischemic stroke, so that's affected tissue. And if our cerebral blood volume is also reduced, then even if we restore flow to this area of the brain, our brain will probably not recover, as it is most likely already damaged and too far gone. So this is what we call our core, or our already infarcted tissue. Okay, so let's look at another example. So again, we start by looking at our two tanks, and we're going to look at the blood flow. So again, on the left, we've got our normal tank, so it has normal flow. On the right, we have our affected tank, so we've got reduced venous return and reduced arterial input, so we've got a decreased cerebral blood flow. So again, on our normal side, we notice that the tank fills almost to the top, but in the case of our stroke side, we notice it also fills to the same level. So this means we have an equivocal cerebral blood volume. So we know we've got a reduced flow, but an equal blood volume. So it is stroke affected because our flow is reduced, but we still have some blood pooling within that brain tissue. So what that means is if we can restore that flow, we're more likely that that brain tissue is going to be viable and it's going to recover from this stroke event. So this is what we call our penumbra. So when we restore it, like I say, it's more than likely going to be salvageable. So there's another map that we can look at that can be quite helpful for us to determine if there's a stroke event and the likelihood of salvaging said tissue, and that is our mean transit time. So mean transit time is basically the average amount of time it takes for blood to flow through a given volume of brain measured in seconds. So MTT increases as a vasodilatory response to reduced flow, and therefore can be a good indicator of reduced flow to the brain. So like I said before, with that auto-regulation, the brain's going to try to save itself. So if it's trying to keep that blood in there for as long as possible, to keep that blood volume high, then we will get an increase in our mean transit time across that bit of tissue. So as well as looking at that auto-regulation, MTT can also give us an insight into a few other things that could be helping us in keeping that brain salvageable. So as we can see here on this right-hand side, we've got an increased MTT, and this is congruent with our decreased cerebral blood flow. As we can see between the two here, our cerebral blood volume is pretty much the same. So what this could be an indicator of is collateral filling. So to keep this blood volume high, even though we know we've got a bit of a reduced CBF, could be that collateral vessels are actually helping to fill this particular bit of brain tissue, and again, helping to keep it salvageable. So these are all things we're looking at to look at the better outcomes possible if we go and retrieve that clot and restore our flow to the brain. Okay, so there's another map that we look at that can be important to determine if there's core or penumbra, and that is what we call Tmax. So Tmax is defined as the time needed by a theoretical unit of contrast media to reach the maximum concentration in one specific voxel. So an increased Tmax, or time that it's taken to fill, indicates a delay in the arrival of the contrast bolus. So if we look at the attenuation curve, we can see that the MTT is the time it takes for the blood to perfuse through the tissue, but the Tmax is the total time it takes for the contrast to reach its peak. So this helps delineate those areas receiving blood flow at a delayed rate when compared to our healthy tissue. So we'll look at the actual curve that the Siemens scanner will give as an example. And we can have a look at a couple of the different things that it looks at. So this is our Tmax. So again, our time for it to fill to a maximum contrast. We've got our CBF, so this overall peak is looking at our cerebral blood flow. And our cerebral blood volume is essentially the volume within this graph. So our mean transit time is how long it takes, again, for that contrast to flow through a particular tissue of brain. So again, as radiographers, this is pretty in-depth. You don't need to know this. We just need to know how these particular results affect what it determines is our core and what it determines is our penumbra, and how this gives us the chance of a better or worse outcome for our patient. So we've got to remember though that our system isn't looking at two tanks, comparing one side to the other. It's measuring thousands of individual voxels within the brain. So if we go back to remembering our CT basics, what a voxel is, so it's essentially the pixel by the detector width, and that is each individual tissue or brain tissue that it's sampling and comparing against each other. So again, this is why any little bit of movement in our scan can really impact our CT perfusion results. So to do this, it creates an attenuation curve. So that's what we looked at for in the last slide. And so it does this for each voxel of the brain and compares them across. So the software is doing a lot of calculations from a lot of scans really quickly. So it's pretty impressive that we actually get these maps generated within a couple of minutes. So it takes that curve, creates all of the data sets compared hemisphere to hemisphere, and it color codes them and spits out these maps really quickly so that we can have a really good indication of that at-risk tissue and our already infarcted tissue, so that our interventionalists can get an idea really quickly on whether there is going to be a positive outcome if they intervene. And then we use these maps, as we looked at earlier with our head and neck angiogram, to see if that clot is in a spot where it's easy enough for us to get into, or not easy enough, but possible to get into to retrieve that clot. So again, not all clots can go to endovascular clot retrieval. Some of them are too far into the brain for us to actually get to. And sometimes the core might outweigh our penumbra. So we might not have any penumbra. So it's already all dead tissue. The patient's delayed getting to hospital. And this is where we come back to time is brain. So every minute that we delay in getting these patients scanned means that more of that tissue is going to become core and will no longer be salvageable. Okay, so what do these maps look like to us when they come through from the system? So this here is off the Singovia workstation itself, so that we've got them all side by side. Not exactly how it looks when it comes through to PACS, but they are the same color-coded maps. So this first image we get here, this is just our quality control scan. So what this is going to do is it's going to highlight for us our arterial input and our venous output as control so that we can see if we think that it's picked the actual vessels and therefore gives us an indication of if our maps are going to be accurate or not. So our next two are our CBF, our cerebral blood flow, and then our cerebral blood volume. So remember, looking at this case here, so this is our scale. Down the side, all of our images will have one of these scales. So this has 0 to 100, and it actually gives us a key here. So that's that milliliters per 100 mil per minute. So down the bottom in our purples, that's 0 mil per 100 mil a minute of flow through that tissue. So as we can see here, we've got a reduced flow. Our next one is our cerebral blood volume, or again, how much blood is within that tissue. So this is our CBV. Again, we've got our scale, and we've got our key of what it is, so mils per 100 mils. So 0 mil would be very reduced volume, and 6 mils is our high volume of blood within that tissue. But again, not everything, we don't want everything to be at this 6 mils, and again, we want to compare our healthy hemisphere to our infarcted hemisphere. So potentially in this case, we see this region here, there's a lot more red when compared to that other healthy side, that non-affected side. And so what this could be is this could be an indication of that auto-regulation that we were talking about earlier. So this side here, although we know it's all got a reduced flow, our volumes are actually higher on our affected side than they are on our unaffected side, which is where we get into our mean transit time. So this is shown here. So this shows that across all of this area of tissue, that blood flow is taking a lot longer to get through our tissue, even though it's still reaching a similar blood volume. So then we've got our Tmax. So we can see that in this area, we've got a really high Tmax. So it's taking quite a long time for that blood to get to that affected tissue. So essentially in this case, because we've got that good blood volume, if we can go in and restore that flow quickly, we can save that tissue. So this mean transit time and this Tmax is showing that there's delayed flow, but the blood volume is showing us that there is still flow. So potentially in this case, we're looking at maybe not a full occlusion of the vessel. There is some blood getting through. So if it's in a spot we can go in and clot retrieve, great. Otherwise, if it's in an area we can't, this is a case where maybe blood thinning agents will help that blood get past the clot and we can keep that tissue alive. Okay, so this is just another way to think of how the software is comparing our healthy tissue to our non-healthy tissue and determining core from penumbra. So over this side, we can see our normal hemisphere. So these are the figures that we've got for this particular brain. So we've got a CBF of 50 mil, a CBV of 5.5 mil, MTT of 4 seconds, and a Tmax of 2 seconds. Over on the other side, so we see 35 mil. So we're not going to compare this to, again, what we think it should be. We're going to compare this to the normal hemisphere. So it's always calculating these back from one side to the other. So if we think that it should be 50 mil, but we've got 35 mil, we've got a reduced flow. If our CBV should be 5.5 mil, but we've got 5 mil, we know that we've got a slightly reduced volume. Our MTT should be 4 seconds, but we've got 8 seconds, so we know that it's taking longer for that blood to get there, which is shown by our Tmax, which is normally 2 seconds, but in this particular voxel, we've got 9 seconds. So it's taking longer to get there, it's taking longer to travel through the brain. We've got a reduced flow overall, but only a slightly reduced volume. So this would be penumbra. So we don't have fully reduced volume, so we know that it's affected by the stroke. All of our flows are reduced and it's taking longer for that blood flow to get there, but we know that that tissue still has a bit of blood remaining in it, and again, if we can restore flow quickly enough, that brain can heal. So in our other voxel down here, so we've got a very reduced blood flow, a very reduced blood volume, a really, really delayed MTT, and it's taking a really long time for that contrast to reach maximum enhancement. So this area we would classify as our core infarct. So even if we can restore flow to this particular part of the brain, it's not going to recover. So just for quick interest sake, this is how Singovia is actually set up to calculate what's core and penumbra and what maps it's looking at to compare the pair. So to define tissue at risk, which is our penumbra, it's going to look at a Tmax of greater than 6 seconds. So anything where we've got a slow blood flow getting to that particular area of brain. Our non-viable tissue is a relative CBF, so that means compared to the other hemisphere, of 20%. So it's not a reduction of 20%, that is 20% of the overall blood flow. So if that CBF is really low, it's going to calculate that as the non-viable tissue. Okay, so to wrap up what's been quite a long video, we've gone through quite a few things. What are our key points that we need to know as RADs performing these scans? Essentially, any area of brain tissue with reduced flow and with reduced volume will be called infarct. So that's tissue that we can't save. Any area with reduced blood flow but similar or increased blood volume, that's penumbra. So that's what we want to see. That's the area of tissue that when we go and bring back the flow, when we remove the clot, that's the area that's going to heal. That's our salvageable tissue. So on our Singo maps, that shows up green. That's what we want to see. So Tmax is another really important map. So that's the time that that contrast takes to reach its peak enhancement. And so that's the indicator that Singovia uses for at-risk tissue. All right, thank you all for watching this video. This is the final video in the 4-part series. I know it's been a long one. I looked through the internet to try and find some good examples of how people have explained the perfusion maps in the past and really struggled. So I hope that by doing the visual aids, comparing it back to how the software actually looks at it, the numbers and the attenuation curves, and hopefully I didn't confuse too many people. Hopefully bringing it back at the start to a really simple explanation and building upon that has helped you to understand what the scan is actually looking at. Again, it's not imperative that you know the nitty-gritty of how all the blood volumes and blood flows are created and how that attenuation curve works. I just find it really good to understand what it's looking at and how this influences what we need to know as radiographers. So thank you all.